For the next session, which is a panel discussion on thoracic surgery, titled Karna's Kavach, we have the speaker with us, Dr. Shiva. For moderating the session, may I request Dr. Manish Kohli to please come forward and take his place on the dais. For the panelists, we have Dr. TVS Gopal. Please on the dais.
Slight changes there.
For our surgery colleagues, we have Dr. Mohib Hamidi. We request you to kindly.
Okay.
Dr. Sanjeev Tuli.
It's okay, let's keep it.
And may I request Dr. Ramesh from physiotherapy to kindly take his place on the dais?
So thank you very much. So the topic for the RE strategy for thoracic surgery, the 15 minutes is definitely, we can't speak even about a single block. So even Divesh will know ESP is going to take more than 30 minutes. So my plan is to just to give you what are all the nerve supply that we need to target. So I'm going to stop at that level and then we will take it on to the discussion. So I wanted you people to actively involve and ask questions so that we can share our experiences. So that is the idea now. So now how I laid my presentation is like this. What are all the thoracic surgery we that commonly encounter and what are all the nerves that carries the nociception during these surgeries. So we will call that as a surgical innervation. So do you understand the terminology? Because when you are doing a surgery, the nerves may, as we cut the structures, the nerves may be different, arising from different zones. So that is, we are calling it as a surgical innervation. Then what are all the techniques that are described to block these nerves? So these are all the three things that I am going to look at it. If the commonest thoracic surgery that we encounter is, one is a breast surgery, another one is the thoracotomies. So breast, if you look at lumpectomy, is only a small area of breast tissue will be removed, and then partial mastectomy, the normal area will progressively increase to total mastectomy, and modified radical mastectomy involves lymph node dissection as well. So this is one of the commonest surgery that we think when we talk about the thorax. Another one is a thoracotomy for various lung surgeries. One is a posterolateral thoracotomy, another one is anterolateral thoracotomy, and for the time interest, I am not going to discuss anything about a sternotomy. So we are going to talk about the breast and then these two thoracotomy incisions. Okay, if you look at the surgical innervation, one is there are two things that we can look at now. One is breast that involves only the parietal wall. So the nerves that goes to the parietal wall, we will call it as a somatic nerves. So that is a somatic innervation. But whenever you talk about a lung surgery, that involves visceral nerve supply as well. So that involves a parietal wall plus viscera, that is a lung. So there we need to block both the somatic innervation plus visceral innervation. However, when we do a laparotomy, there is a parietal wall also is involved. Then we have to, when you are placing an epidural, we will look at what is the sympathetic chain so we will look at that as well, because we need to relieve the visceral pain as well. So this is the basic difference. When you talk about the breast, it involves only the parietal wall. When you talk about the thoracotomy and lung surgeries, that involves viscera as well. So now you will look at the nerve supply. The breast supply is well established now. The breast receives nerve supply from three areas. One is the supraclavicular nerves, which comes from the cervical plexus. That is what we have seen today. We have injected selectively into the supraclavicular nerve that supplies the skin below the clavicle. And then the next bigger chunk that what we get is the brachial plexus element. These medial pectoral nerve, lateral pectoral nerve, long thoracic, thoracodorsal, and medial cutaneous nerve of arm. All these things supplies the muscles that involves into the chest wall. That is, a pectoral is major, minor, latissimus dorsi, serratus anterior, because whenever they do a modified radical mastectomy, they are going to strip off all the fats from these muscles. They are essentially pectoral girdle muscles. The pectoral girdle muscles receives its blood nerve supply from the brachial plexus. the breast substance itself, that receives its nerve supply from the intercostal nerve, T1 to T7. So very simple is, the breast substance receives its nerve supply from the intercostal nerve, whereas the muscles in the chest, they receives their innervation from the brachial plexus. So these two things, the myoto, the muscles of the chest, brachial plexus, the breast substance and the intercostal muscles and the ribs receives nerve supply from the intercostal nerve. So there are two plexus involved. Only when it comes to the skin, the upper part of the breast, just below the clavicle, the area is supplied by the supraclavicular nerve. I think, am I clear? So you can stop me anytime that if you have any clarity. So that is about the parietal wall. Breast is in the parietal wall. These are all the three supplies. Predominantly brachial plexus and then the intercostal nerves from T1 to T7. Only the upper part of the breast receives supraclavicular nerve, that is from the cervical plexus. So when it comes to the lung, after you are breaching the parietal wall, goes into the lung, the one nerve that you need to again look at is this phrenic nerve. Because the phrenic nerve that supplies the visceral pleura very intensely. The pleura on the diaphragmatic surface as well as the medial side, the phrenic nerve supplies the visceral pleura heavily. So that during a thoracotomy and lung surgery, the phrenic nerve also going to be one of the nociceptive route. If you block only T1 to T7, still the patient is going to have pain because the phrenic nerve is going to carry significant nociceptive load from the pleural surfaces. So you think about phrenic nerve also, I will come back to it later. And then apart from phrenic nerve, the sympathetic and parasympathetic. Like if you go to the gut, you will talk about the sympathetic celiac plexus that supply the stomach and the bowel. We will take care of that as well. Similarly, in the lung also, the sympathetics and the parasympathetic make a huge plexus of network, and that is going to innervate the substance of the lung itself. Okay? So we need to, from the sympathetic, the primary sources from T1 to T4, the sympathetic fibers, whereas parasympathetic is predominantly from vagus. So the parietal wall, it is from T1 to T7 intercostal nerves, and then muscles, brachial plexus, supraclavicular nerve, a small part of skin on top. Okay, that's a parietal wall. When you goes into the chest, phrenic nerve, sympathetic nerves anyway from T1 to T4. So if you block from T1 to T4, that is get involved anyway. The vagus nerve is another source. So you keep these things in your mind. So now to just summarize, if your surgery is only involves the parietal wall, that is a breast surgery, you have to target only these nerves, the supraclavicular nerves, brachial plexus, intercostal nerves from T1 to T7. So these are all the nerves you need to block for a complete deafferentation of the breast. So if you do a lung surgery, that involves a viscera as well. So that we need to target phrenic nerve, which is arising from C3, C4, C5. The sympathetic system is again coming from T1 to T4. During the intercostal nerve blockade, that is anyway going to get involved, so I am leaving it out. Apart from that, vagus, the parasympathetic is left out. You just keep it in your mind, I will come. So now what are all the techniques available to block these nerves? If you look at a supraclavicular nerves, either you can do a simple skin infiltration above the clavicle or selective supraclavicular nerve block, which we have demonstrated today morning. So it's only 3 ml of local anesthetics. You can block the supraclavicular nerves. When it comes to the brachial plexus, we have a range of blocks. Our conventional brachial plexus block we can do supraclavicular or costoclavicular. Apart from that, PEC1 and PEC2, these blocks are proposed to produce a blockade of all these 4 nerves. Intercostal nerves, we have a from the center to the periphery, we can put a thoracic spinal, thoracic epidural, thoracic paravertebral block, and the erector spinae, serratus anterior plane block, pec block, and parasternal block. So from posterior to anterior, there are a lot many blocks are there. Then coming to the phrenic nerve, because we wanted to avoid so far phrenic nerve, but in case of lung surgery, that is one of the important component you need to consider. Either we can do these block directly at the interscalene groove while you are doing a brachial plexus itself, this will get involved, or we can infiltrate. When they are doing a thoracotomy, we can directly see the phrenic nerve inside the thorax itself. During the periphrenic pad of fat, we can infiltrate local anesthetic by the surgeons directly. So that is also one of the way that we can block that nerve. So coming to the block technique as such, So already 6 minutes only left. The cervical plexus component, I will leave it out because anyway we have demonstrated it today. So I will skip it. So for the cervical plexus, our choice will be selective supraclavicular nerve block, what we have showed today in the morning. That is how we will do the supraclavicular component. Coming to the brachial plexus component, we have lot many options. If you look at the brachial plexus, you just see this is pectoral is major has been cut off, this is minor. Basically these four nerves is going to supply the muscles of the chest. The lateral, the long thoracic nerve that is going to supply the serratus anterior muscle. The thoracodorsal nerve going to supply the subscapularis muscle, and then lateral and medial pectoral nerve is going to supply the pectoral muscles, because these are all the muscles going to involved while they are doing the modified radical mastectomy. They are going to separate the breast tissue from all these areas. So if you look at even more closely, you can see very clearly this is a long thoracic nerve that supplies the serratus anterior, thoracodorsal nerve supplies the subscapularis muscle, and then medial lateral pectoral nerve for the pectoral muscles. So these are all the four nerves, these are all the muscles involved in the breast surgery. So this is a cut section of the thorax. So this is a pectoralis major, minor, this is the rib cage. While you are doing the long thoracic nerve is going to go on to the medial side along the chest wall. The medial lateral pectoral nerve is going to come on to the roof. The thoracodorsal nerve is going to go on to the floor. This is a complete fat-filled axillary tunnel. So when you do a PEC 1, PEC 2 block, we are going to inject the local between these two. PEC 1, between the pectoralis minor and the serratus, we are going to do a PEC 2 infiltration, isn't it? Or we are going to put 10 ml there, 20 ml there. So we are going to inject 30 ml of local anesthetic to block these small four nerves. So here you can see very well, the lateral and medial pectoral nerve is on the roof of the triangle. The long thoracic nerve and the thoracodorsal nerve is on the floor. The long thoracic nerve on the medial side. This is the axillary tunnel completely filled with the fat. So this is why we need 30 ml here to block these four nerves in PEC 2 block. So for only four nerves supplying these four muscles, but we need volume of 30 ml because most of the drug is going to get consumed by this fat. So it is too costly, isn't it or not? But if you look at the costoclavicular space, which is much closer to it, if you put 10 ml of local anesthetic there, we can get all these four nerves blocked. And even while they are doing the surgery, because the arms will get hyperabducted in all the modified radical mastectomy, the surgeon is going to keep the hand like that. So we wanted the shoulder also to be paralyzed so that the patient can keep their hand for a length of time. So by doing a costoclavicular or supraclavicular, 10 ml of local anesthetic, you can block all these four nerves with a good shoulder paralysis so that the patient can keep the hand in an abducted position for a longer time. So our choice for all the brachial plexus event is for, we will do a costoclavicular block, 10 ml of local anesthetic. So that will serve the purpose. Then coming to the other thoracic, you can see from the center to the periphery, we can do a spinal epidural, and then we can do an ESP at this level, intercostal nerve blocks, and then serratus plane 1, then plane 2, pectoralis PEC 2, then the parasternal block. So these are all the various options available for the intercostal nerves. So if you do a PEC 2 and SAP, they are not complete intercostal nerve block, they are going to only block the lateral branch of the intercostal nerve. So the analgesia is going to be only on the anterolateral surface. So it is not going to block the entire intercostal nerve, it is going to block only the lateral branch of the intercostal nerve. So only anterolateral aspect of the breast is going to get anesthetized, not the medial side. If you go to the parasternal block, it blocks only the anterior, the medial half of the breast, not the other areas. So these are all the disadvantages. So if you put together, we can categorize these blocks into two categories as far as the intercostal nerves concerned. One is a nerve block, another one is a facial plane blocks. The nerve blocks can be spinal, so this blocks both the ventral rami as well as the dorsal rami. Epidural, ventral rami as well as the dorsal rami. Thoracic paravertebral, depending on where you are injecting. See, today morning we have shown the most medial injection. When you inject at that place, you will block both ventral and dorsal rami. But if you inject lateral to the transverse process, you will block only the ventral rami. You will spare the dorsal rami. That is why I put it up, ventral rami plus or minus dorsal rami, depending on where you are going to inject. Intercostal nerve block is going to be only the ventral rami block. So similarly, ESP is predominantly works on the dorsal rami. Its efficacy on the ventral rami is not that great. So we can't provide surgical anesthesia with exclusive erector spinae plane block. If you do a SAP and PEC, it is only the lateral branch. So only anterolateral surface is going to get affected, not the medial side. So parasternal block only blocks the anterior branch of the intercostal nerve. So this is a rough categorization of blocks available for the intercostal nerves. So in that, what are all the options that we have? Thoracic spinal, I don't have any experience on that, but in a theoretical concern, it's technically more challenging than the lumbar spinal. It's single shot. We can't prolong the surgical anesthesia as well as analgesia. Limiting the LA spread to the desired level is usually a challenge, because once you put in the drug into the intrathecal space, however selective we are, there are so many things beyond our hands. Continuing into postoperative analgesia is not possible. Whereas if you place a catheter, then we can do it as a segmental, because we can able to titrate it. We can prolong the anesthesia as well as we can continue it in the postoperative period for analgesia. And truly segmental. Now the real-time ultrasound guided thoracic epidural catheter placement give us a more edge, because we can clearly identify the target and place the catheter, use it very for a desired segmental level. So that is where I will stop now. We will go for how we will do real-time guided everything that I have. I think we can move on to the panel discussion and then see what we can take it from there.
A few years back, I went to such a regional anesthesia conference, and I started giving the PEC block for my chest wall surgeries. Not all the time the effect comes. Then I again, 2 to 3 years later, maybe 3 to 4 years back, I again went to another regional anesthesia conference, and I learned about giving the paravertebral blocks, so that I can give a complete analgesia to my patients. But still I wasn't able to achieve adequate analgesia to all my patients who has come to me for the thoracotomies or the chest wall surgeries. And I regret that Anshuman hasn't organized Anshuman Con till date, so that I should have listened to Dr. Shiva's presentation and choose my blocks adequately. So let us begin with some of the questions that I want to put forward to my esteemed panelists. Welcome, sir. Welcome all of you. First of all, we have a case of a breast limb for the excision and biopsy. I want to ask Dr. Praveen sir, whether is there any correlation between the location and size of the breast limb and the post-operative pain scores? And we always say in terms of the breast limbs. What about the gynecomastia surgery? Is the intensity of pain for the gynecomastia surgery and the breast limb same, or is there any difference?
It has nothing to do with the location of the breast lump for the post-operative pain score. Definitely if the size is more, definitely the pain has to be more. Location has nothing to do with post-operative pain score. Another question is, gynecomastia surgery.
Yeah.
Definitely in gynecomastia surgery the pain is more as compared to breast lump surgery, because we have to do this involves all the 4 sections, 4 quadrants, and also it involves 2 surgeries. One is the removal of fat in gynecomastia and another is the removal of tissue also. So pain in gynecomastia surgery is more as compared to breast lump surgery.
Okay, sir. Thank you. So we all agree that the gynecomastia surgery is more painful as compared to the breast lump surgery, and maybe sometimes when the lump is below the areola level, maybe because there is a lot of innervations of the T4 area or the T3 area, then it may cause some more pain as compared to other structures. My next question is for the Dr. TVS Gopal sir. Sir, are there any current recommendations for the daycare surgeries that whether the block should be given?
The ERAS protocol basically concentrates on providing effective analgesia with minimal reliance on systemic opioids, a reduction in the incidence of complications from analgesic procedures, and also reducing the average length of stay. Now, neuraxial blocks, as per ERAS protocol, are considered to be invasive and technically more challenging. Whereas para-neuroaxial blocks, such as ESP, which are supposed to be surrogate approaches to the thoracic paravertebral, and chest wall facial plane blocks are said to be less invasive. So building these blocks into a multimodal, multidisciplinary analgesic regime would be more advisable as per the ERAS protocols than, say, a neuraxial block.
Then a neuraxial block. So we advocate facial planes block for the daycare surgery, like the breast lumpectomies and everything.
Yes.
Yes, to provide adequate analgesia. Sir, whenever we give Hamidi sir, whenever we give these facial plane blocks, do you think that the drug deposited in the preoperative area will interfere with your surgical field and your surgical things?
No, it doesn't, because the day I was doing a thyroidectomy, they had to give local infiltration of blocks, and there was no difficulty in doing any dissection.
Okay, I hope
Because
that.
basically I do more laparoscopic after
Okay,
surgery,
okay, sir.
and I will like to share my experience. They are giving such a beautiful blocks, so my lap pulling patients are going home the same day in the evening. Like today I did 2 lap pulleys and they gave the block before the surgery. Right now they are pain free.
Okay.
They are saying, Dr. Saab, there is no pain at all.
Thanks
So
to you, sir.
These blocks have done wonders to the patients.
Okay.
The patients are happy the next day, they are sitting, most of the patients, they are going home very next day. Lap appendectomy, lap hernias, lap pulley. Now I'm planning to do it as a daycare surgery. In the morning we do the surgery, by evening, or late evening, they go home.
I hope Dr. Praveen sir also feels the same. For the breast surgery, if we give the local anesthetic in that
We
particular,
don't.
you.
Sometimes the local anesthetic come when you dissect laterally.
Okay.
But it's okay.
It's okay.
Patient
It's-
is pain free, we are happy
Patient
with
pain
it.
free.
That is it.
There are some concerns that some surgeons may feel that it may interfere with the cauterization
When you come laterally,
when you come laterally, then
Then
we are deposited.
definitely.
Okay. Gopal sir, I think the surgeons are quite happy when we are giving the PEC blocks for the breast analgesia surgery. But do you really think that in this particular area of the multimodal analgesia, are these facial plane blocks an overkill for some minor breast lumpectomies, or a simple local infiltration by the surgeons will do?
Well, I'm sitting on stage with 2 surgeons.
2 surgeons, so
So let me say something. It actually also reflects my own opinion. Facial plane blocks for minor breast surgeries, such as removal of a simple lump, probably is an overkill. I think local infiltration and reliance on other analgesic techniques like oral medications should be enough. And yes, as he said a while ago, it also definitely depends on the size and the surgical extent. So if the size were to be large and the surgical extent of the incision were to be large, yes, we would consider doing a chest wall block, and preferably a PEX 2.
PEX 2 block.
And we would definitely give it pre-op.
Okay. So suppose the lump is on the middle side of the chest wall, the middle to the midclavicular line extended to the lateral line.
A parasternal block would be more advisable, because the area from the sternum to the nipple or thereabouts would be covered by the anterior cutaneous branches of the intercostal nerve. So superficial parasternal SPIP, as we call it today, would be quite all right.
Okay. So multimodal analgesia plus multi-block analgesia will also be there. So we are giving 2
Yes,
blocks, the PEC
it
blocks
would-
plus the, okay.
It would depend on the location, that is one, the size as well as the surgical extent.
Okay. Thank you, sir. So now I think the problem is solved that, yeah, please.
Sir, I have a small thing. Even though it is not with the breast surgery, it is with the generally with the thoracic surgery.
Okay.
Post-operatively. So most of the people, when you try to reduce pain, in fact, this post-operative complication is, one is lung compliance and one is atelectasis in any patients who are undergone a thoracic surgery. How much anesthesia you give so that the patient can cough effectively, as in the meantime the pain can also be taken care? Any guidelines you have in this?
Dr. Siva sir wants to answer.
So that is the essential aim of our post-operative analgesic plan. So the core outcome that we want is we should get the full functional outcome. Full functional outcome means the patient has to take a deep breath and able to cough effectively, and he should be able to do incentive spirometer. In that, at least he should be able to pull up 2 balls, up and hold, which he was doing in the preoperative period. And then he can able to sit and move around. If you are not achieving these 3 goals, that analgesic is ineffective. So we call this analgesia as a dynamic analgesia. We don't want it to make the patient bedridden and give a complete analgesia is a kill. We are not going to increase the patient's benefit, but we are going to increase the complications only. So we need a dynamic analgesia where we are achieving all these outcomes without compromising the analgesia. That is what we are looking at. For that, the regional is the only way to go. We need an epidural catheter or paravertebral catheter only can able to achieve this. There we can titrate the concentration of local anesthetic in such a way it will not produce any paralysis, but it will provide only pain relief. So these 2 regional blocks alone can give a dynamic analgesia. While they are moving, coughing, if they want it to pain free, we need to block the nerves. The concentration has to be manipulated in such a way that will not produce any sensory motor deficit, but blocks only the pain fibers. So that is possible.
Number 2, sir, one more thing. In fact, I myself was a patient. I had to undergo a neck dissection, and sir was my surgeon, and Dr. Anshuman was the anesthetist. And in fact, I went without pain and came back without pain, and I was fine. So compliments to both of them.
Both of them.
Thank you.
Anshuman Khan. Great. I think Siva sir has mentioned in his discussions that there is a small difference between the modified radical mastectomy and the radical mastectomies. So just for the benefit of delegates, I just want to ask Praveen sir that what's the main difference between the modified mastectomies and the radical mastectomies, and how often you manipulate the pec major or the minor muscles, and how often you extend the incision to the axillary area? Because these are the times that we need to give some extra local anesthetics in a particular plane, and these things should be taken care of.
There are 4 questions. Number 1 is what is MRM and what is the difference? MRM is modified radical mastectomy, which everybody knows it. It is you remove the breast, nipple areola complex and some part of skin and axillary lymph nodes. In radical mastectomy, a part of we have to remove the pectoralis major muscle also. If the tumor involves the pectoralis major, so in that case we do the radical mastectomy. How often? Pectoralis minor. How often we need a pectoralis major? We don't cut in MRM. We have to do nothing with it.
Okay.
And only in radical mastectomy, when it involves the pectoralis major muscle, then we have to remove that.
Pec major muscles also.
Then it becomes a radical mastectomy.
Okay.
And minor, there are 2 ways we have to do axillary dissection. One is Patty's modified radical mastectomy. In that we remove the minor muscle, pectoralis minor. And other is Eschenklaus. In Eschenklaus we retract the pectoralis minor muscle and we do the axillary dissection to remove the level 3 nodes.
Okay.
For the level 3 nodes, we have to, some people cut it, that's a Patty's, and some people retract. Most of the people retract nowadays, and they don't cut the pectoralis minor muscle.
LD flap you?
The axillary area. LD cover flap is required only in case of when we have to do the reconstruction.
Okay. Nothing, no,
Reconstruction.
not otherwise. So
Otherwise,
practically speaking, per year, sir, you do mostly the MRMs only.
no,
It,
no. Nowadays, it has nothing to do with MRM.
So,
Nowadays, people most often do the breast conservation surgery.
Okay.
In breast conservation surgery, we have to give a incision in the axillary area.
Okay.
In MRM, we don't have to reach to the axillary area. We stop at the anterior axillary line. But in breast conservation surgery, we have to give incision in the axillary area. That is the thing.
Okay, sir. Thank you very much,
Because
sir.
we have to remove the breast lumpectomy separately and axillary dissection separately.
Now the protocol has completely changed. If somebody gets breast lump, we do trichotinal biopsy and we get ER/PR HER2 test done. Then chemotherapy is given for 6 weeks to reduce the size of the lump, and we tag the axillary lymph nodes, and this is followed by BCS and axillary clearance at the same time.
Okay. Thank you
Everybody
very
is practicing this unless it is advanced CA breast.
And I must thank Dr. Shiva sir again because he has told me today, like that, yes, so that the chest wall and the thoracic area has 3 supplies. So,
So what are all the questions?
So the choice of block, depending upon the extent of surgery, as sir has
Yeah,
said,
yeah,
that most
yeah.
of the
Now-
BCS is being done right now.
Yeah, now what blocks should I do all these blocks for all the breast is one question that we are looking at it. Suppose your the lesion is within the breast gland, that is fibroadenomas and minimal lumpectomies and so on. Like fibroadenoma, lumpectomy, mastectomy, breast conservation surgery. Essentially the stimulus is going to be from the breast substance only. Okay? Then it is involves the primary nociceptive sources ventral rami from T1 to T7 intercostal nerve. It's exclusively only the intercostal nerves because here we are not going to touch the muscles of the chest. They are receiving nerve supply from the brachial plexus. So here only the intercostal nerves are involved. So if you are looking for a surgical anesthesia, you wanted to do only under block, it's only a thoracic epidural or thoracic paravertebral block only can do this. Because we are targeting only the intercostal nerves. Suppose if the surgery involves, like as sir said, the pectoralis major muscle, serratus anterior, latissimus dorsi, like in modified radical mastectomy or radical mastectomy, then we need to, like total mastectomy, modified radical breast implants, reconstructive surgery, then we need to, along with the T1 to T7 intercostal nerves, we need to add up the brachial plexus elements also, because the myotome receives its nerve supply from the brachial plexus. So there, if you wanted to do a surgical anesthesia, either you have to do a thoracic epidural or multi-level thoracic paravertebral block, plus for the brachial plexus element, you can do a costoclavicular or supraclavicular brachial plexus block. The other question Manish has asked, whether we can add any facial plane blocks in terms of brachial plexus. Facial plane blocks is never stand, the surgical stimulus. That is what is our experience. So here if you look at this is one awake modified radical mastectomies. So we do a multi-level, this is a Dexmed infusions will be going for a procedural sedation. Patient will be having some musics to play around. So if you look at, the surgeon is separating the breast substance through cautery only. I think now all the younger generations will use entire dissections through the cautery. This is 30 to 40 watts current. So this is a real test for your nerve block. See, facial plane blocks doesn't stand this. So they have to separate entire breast substance like this because they will fire all the free nerve endings. So none of the facial plane blocks can produce such a degree of deafferentations when it comes to the surgical anesthesia. So that is why we are relying on a more of a nerve block than the facial plane blocks. So as sir said, here the pectoralis, can you see that that's a pectoralis major muscle and the pectoralis minor muscle has been retracted as exactly mentioned by the surgeons. The axillary dissection also by the cautery. So there will be, the cautery will stimulate all the free nerve endings. You can't, the stimulus is not at one point. So unless you produce a complete conduction blockade, the patient is not going to be pain free. So that is why we rely on more of a peripheral nerve block rather a facial plane block. So I think is it...
Yes, sir. You answered my query and also the next question for Dr. Prithesh Gopal, sir.
Then I will just play one more. Can you have a audio in this? So here you can just, the difference between, as I already told it, complete deafferentation I mentioned many a times. So this is a case what you have seen before. It is done under multiple paravertebral plus costoclavicular block. So this is the patient, this case we have done in the morning. It took a bit of time. You can listen from her. This is about 3 to 4 hours after the surgery. My resident is a final year resident. He is interviewing the patient. He is not on the team. So we ensure that there is somebody else will ask the patient so that it's not biased. What is their communication? So I will play from the beginning.
कल आपका सर्जरी हुआ तो आपको कैसा लगा?
अच्छा लगा। हमको तो पहले चिपटा कर दिया, एक तो उल्टा दिया, उल्टा देने से हमको इंजेक्शन सब दिया है।
You see which hand she is using? Left hand.
करके सर्जरी हो रहा है, कुछ पता चला।
कुछ नहीं पता चला। थोड़ा भी आपको कुछ पता नहीं चला।
पता चली से पीछे वही जो ये करा है ना, पाइप गिर था, लाश गला, एक जाने के लिए तब पता चली से टू लगी से आग कुछ।
उससे पहले कुछ नहीं पता चला। तभी जस्ट वो जब ट्यूब डाल रहे थे तभी आपको पता चला। आपको और कुछ याद है क्या सर्जिकल टेबल पे सर्जरी के टाइम? सब याद है।
मुझे ये कैंची सब ले रहा है, जंतर बोला है, अपना मुंह से बोल रहा है।
This is a left to modify radical mastectomy. You see the way she uses the hands.
मुझे फिर नींद टूट गया है, टूट जाने से फिर सब काम में सुनना पड़ता सब कर रहा है।
बट आपको उस टाइम में दर्द हो कुछ नहीं था। वो जो ऑपरेशन कर रहे थे वो आपको पता चल रहा था कि नहीं पता चला?
ये तब पता चल गया।
पता चल रहा था? नहीं पता था।
नहीं।
सिर्फ आपको दर्द तब हुआ जब वो लास्ट में ट्यूब था।
तब
बहुत ज्यादा दर्द थोड़ा दर्द?
नहीं, खूब थोड़ा दर्द।
थोड़ा होता है।
5 hours after.
ऑपरेशन टेबल पे लास्ट आपको क्या याद?
लास्ट क्या याद है? सब हो गया है, गला काटे हैं, सब पहुंच पाँच के सब पूछा पूछी करता है, तो याद है।
याद है।
सब याद है। पूछा पूछी कि हो गया है, हमरा दिल में लगा कि हो गया।
ठीक है, कितना आपने बोला बता दिया। मैं आपको और एक क्वेश्चन पूछता हूँ। आपको पता है कितना देर तक सर्जरी चली?
3:30 बजे तक।
3:30? आपको लग रहा है सिर्फ 3:30 बजे तक? 6 घंटे का सर्जरी और आपको 6 घंटा कुछ दर्द नहीं हुआ, सिर्फ वो पहले जो इंजेक्शन दिए उतना ही याद है और लास्ट में जो आपको पाइप डाला ड्रेनेज का उतना ही याद है, ये तो कुछ याद नहीं। ठीक है, धन्यवाद।
So I mean, I don't understand Hindi, but I think from her face and the way she uses the hand, she is a left modified radical mastectomy. This is about 5 hours after. Even she is a right modified radical mastectomy. You see the way she is using an hand. What does it indicate? Zero pain. Absolutely, there is no hesitation to use. She preferentially uses the right rather than left. So this is the benefit of deafferentation. So the stress response is zero. The autonomic nervous system of the body doesn't know that such a surgical nociception has happened to them. So this is what is the benefit. So deafferentation is the core that we should have. So conduction blockage should be our core clinical practice. That's what I wanted to impress upon.
Thank you very much, Shiva sir. Sir, in this particular patient, you have given the paravertebral block. And single level or multiple levels?
This is a multi-level because it's a quite complex. It's not easy, that easy. It needs a big learning curve. But after the epidural comes in, so we shifted from thoracic paravertebral to the epidural. Initially, thoracic epidural also is more challenging, isn't it or not? Yep. Now with an advent of ultrasound, we can do very easily. So that is what today morning we have shown a lumbar prone position single pass. Similarly, thoracic we can do a single pass. So with that sort of a capability, we can provide a segmental precise epidural catheter placements, and we can give only with 3 to 5 ml we can achieve all this T1 to T7 you can block, and 10 ml into the costoclavicular. So awake breast surgery has become a common practice now.
Okay, thank you very much, sir, because till date I hadn't done any awake breast surgery, given anesthesia for any awake breast surgery, but now, you know, after listening to your presentation, definitely I'll try to do some things with my surgeons. Sir, next question, it's a vague question. Suppose a patient comes to us with a flail chest, with a fracture of the 5th, 6th and 7th rib, and he was in extreme pain, and definitely he was not able to take adequate breaths. So, do we give any facial plane blocks? Because putting in a epidural catheter in such kind of patients is definitely a gold standard, because we can keep the catheter for 10 to 15 days. But for positioning the patient to get to give a epidural is also very painful. So can we give a facial plane block if a single site fracture at multiple ribs level is there?
Yeah.
Maybe anteriorly.
So this we quite commonly encounter. The one area where I personally felt the facial planes play a significant role is these rib fractures, especially the serratus plane block 2, because most of these rib fracture patients has got the varying amount of subcutaneous emphysema as well. In any one of the plane, if you can able to identify the rib, if you hit the rib and then inject about 20 to 25 ml of 0.25% bupivacaine, the deeper plane, between our second, third or fourth, whichever the rib that you can see, the pain relief is so intense and immediate, profound, so that their pain will come down by 50 to 60% immediately. They could able to move the hand, they could able to breathe well. So the serratus plane block,
Superficial, deep. Not
because that is superficial is again, it is superficial, the local is going to take a lot of least resistant paths. But once you go to the deep, the extent of spread is less, but the analgesic intensity is much, much more. So there we have even placed the catheter, obese individuals where we can't turn them prone and all. We kept the catheter for 4-5 days. That is where even the posterior fracture somehow it works well. Even anterolateral, anterior, even the posterior 1/3 fractures, these deep serratus plane catheters works well. So that time we were wondering maybe the muscle contusion or muscle pain that is predominantly causing the problem. See, once you give a local and then release this myogenic pain, the patient feels much, much better rather the bone pain. So that's what we were thinking, how this, the deep serratus plane works well. So the deep serratus plane block is one of the block that you can advocate in fracture, rib fracture. Then we will make them prone and do a thoracic epidural nowadays.
Thoracic epidural, not a problem. Thank you very much, sir. Sir, is there any difference between the VATS thoracotomy and VATS bulectomy? Oh, sorry, VATS decortication surgery and VATS bulectomy?
In VATS decortication, we remove the thick pleura which is on the lung so that lung can expand. And in VATS bulectomy, we remove the bulla. If any air space which is more than 1 centimeter is a bulla. When it increases in size, this pushes the lung to one side. So in that case, we have to do bulectomy. We have to cut that part.
So for such surgeries like bulectomy or decortications, do a plan of perioperative analgesia changes, because the surgeons will remove the pleura from the medial side. So I think that there is a breach in the continuity of the paravertebral spaces, the boundaries of the paravertebral spaces. So do we need to change our analgesic plans in the perioperative period?
So actually we evolved a lot on these these lines. Initially what we do was we were doing, while they're opening we can see and do a multi-level intercostal block itself, because we are directly seeing inside the cavity. We can do it because many a time we did a direct injection of local anesthetic in the paravertebral place itself. And sometimes we will put a needle from outside and place the catheter under vision.
Under the vision.
Because we can see inside, create a space and then push. That is also we
That
did.
is also
We infiltrate by seeing.
Yeah, through the vat itself we
And
did. So that
can also give the intercostal.
so direct injection through the during the surgery, then we can put a needle and place a catheter. The surgeon will place the catheter. From the back we will introduce the needle, push the catheter so that they can place it in the paravertebral space and do it. That is also we did it. And then later when we used an ultrasound, we did a paravertebral block, but the challenge is there will not be a pleura. That is the challenge because different amount of effusions will be there and things like that. Now with an advent of epidural, we have gone away with all these things. We place a segmental epidural to
catheter.
cover all these things.
Okay.
So these are all the various options
Nothing
available.
like ESP blocks or electroacetl paravertebral space blocks, nothing.
So these are all less efficient because once we have a dense peripheral nerve block, unless we couldn't able to access these areas, we rely on a lighter facial plane blocks. That is how I will take it. So when you are able to achieve a complete conduction with the peripheral nerve block, I would rather choose that than the facial plane, which is going to be less intense in terms of analgesia.
Okay, thank you. So do you really feel that when we provide adequate analgesia to our patients for thoracotomy or the VAT surgeries, the recovery of the patient really enhances and there is the discharge criteria for the patient from the hospital?
You are talking on physiotherapy point of view?
Therapy point of view.
Yes, sir. If the patient is able to do proper, breathing exercise, like sir explained in the last question, if he is able to pull up the spirometer 2 balls and blow it and if not cough, at least to huff properly, and if the shoulder movements are okay, I think it makes a point in early discharge. No doubt.
So do for some CABG surgeries apart from epidural, the post CABG surgery the patients are on the heparin infusions and some anticoagulants. So can we do something to give them continuous analgesia for the next 2 to 3 days?
I'll give to
Deep, in fact, started parasternal catheters in Medanta when he was working there. So you can say he is the pioneer for parasternal catheters following CABG in our country. Taking a cue from him, I spoke to my cardiac surgeons. We did a series in 6 patients wherein we placed parasternal catheters. It works wonderfully well.
Okay, sir, any continuous ESP catheters that they are talking about nowadays, that we can put bilateral ESP catheters in thoracic region? In the
Bilateral ESP catheters, again, Dr. Philip Macaire in Vietnam. He's published a paper on this.
Yeah.
I personally believe that an erector spinae plane block does not consistently provide analgesia for anterior procedures. So I would not advocate or do an erector spinae plane block till such time we have more understanding on the way it works and how to make it repetitively successful in all patients. But if Deep wants to say anything else?
No. Sir also agrees with you, sir, as always. Anyway, sir, you want to say something?
See, as far as this, the Philip Macaire, the ESP block might work better in a pediatric patients because I think his work is predominantly on the distance between the erector spinae plane and the paravertebral space is very less. So the local can very easily seep and go to the paravertebral space in a thinner, smaller kids. But in the adults, it's not the same. Because we have a basic science research where we found, have you seen the paraneural sheath is a very thin membrane around the sciatic nerve. See, we took out this paraneural sheath and put a local anesthetic on one side. And then we looked at how much local come to the other side. See, when we put a 1% lignocaine, that is 10 milligram per ml, that is 10,000 microgram per ml on one side. Paraneural sheath is only about less than an mm. It's in the microns only, the thickness. So when we looked at how much lignocaine crossed to the other side, you know that at the end of 1 hour, we got only 1000 micrograms. At the end of 1 hour. So such a thin membrane itself will provide a significant impedance to the local anesthetic diffusion. So putting a 1 centimeter away and then thinking that it is going to work on the dorsal rami, it's not.
It's not possible.
Some amount of drug might reach, but the concentration when it reaches that site, it is going to be lesser and lesser. Suppose if it works on the dorsal root ganglion, then it might produce some amount of analgesia. That is why it is not consistent. Chronic pain, it might work better because the mechanisms are different. So that is why the peripheral nerve blocks are more 100% effect, whereas facial plane blocks, depending on how far you are away from the nerve, the analgesia is going to be lesser and lesser.
Thank you very much, sir. Thanks for participating in the moderation. Thank you, sir. Thanks for giving me words.
May I request Dr. Deep to kindly help us to felicitate our faculty. First, Dr. TVS Gopal. Thank you, sir. Dr. Mohib Hamidi. Thank you, sir. Dr. Sanjeev Tuli. Thank you, sir. And Dr. Ramesh. Thank you, sir.